I'm Tim Block from the Hepatitis B Foundation and Blumberg Institute, as Steve just said, and I'm here. I represent about 30 faculty from our center who work entirely on hepatitis B and liver cancer. Now, these are my disclosures. As you can see, there's room. No, I'm actually, for anyone out there in a company, your name here, if you wish. All right, that's a joke. I know it's been a tough night with, all right. This is the last talk of the session, and I'm going to go through it very quickly, but I'm going to be talking about morphogenesis inhibitors. That is basically talking about inhibitors of the viral envelope protein, or S antigen. It's really the less glamorous cousin of the other direct-acting antiviral targets. There's a lot of focus and talk about, obviously, polymerase inhibitors, cccDNA inhibitors, capsid inhibitors, and there's relatively little action in the area of envelope proteins. So first, let me explain what they are. This is a cartoon or an illustration of the virion and the subviral particles, and the yellow is showing you the S antigen or envelope protein, and what I have on my tie is actually the original electron micrograph taken by Manfred Bayer and Barry Blumberg of the hepatitis B, really subviral particles. And what the point I want to make here is that the S antigens, which are all made from the same open reading, from the same genes, alternate starts of open reading frames, L, M, and S, the major one, are essential viral proteins. Without an S antigen, the virus is not infectious. It's as legitimate an antiviral target, really, as is any other direct-acting antiviral target. But in addition, there is subviral particles which are made remarkably, as you all know, in vast excess to the amount of virion that's made. People have microgram amounts per milliliters of S antigens in their circulation. So there's been a lot of talk about extra virological roles for S antigen, not just as an essential viral protein to complete the virus life cycle, but perhaps roles in dampening the immune system. It seems somewhat logical. So let's explore some of those. Possibilities. I'll do that first, and then I'll talk about some direct-acting antiviral agents targeting the S antigens. Well, the first thing that people have talked about for years is if you look here and look at this illustration showing the subviral particles in the circulation I'm trying to show, and antibodies shown here in the red, it was a simple theory to say that if you eliminate the S antigens in the circulation, you'll unmask hepatitis B surface antibody. This is antibody to surface antigen, as you all know, is undetectable mostly in people with chronic hepatitis B. It's one of the definitions. But perhaps people have it in their circulation. It's just complexed with S antigen. So that would be pretty straightforward. This is sobered somewhat by the knowledge that, at least in spontaneous cases where people clear S antigen who have chronic hepatitis B at some rate, a little less than 1% a year, it usually takes, what I'm showing you here, I made this myself, is it takes months to years before S antibody it can declare itself, before you can detect it. Not saying it wasn't there to begin with, but that makes us pause a little bit. It takes a long time, is the point here, at least when there's spontaneous resolution of S antigen. Not to say that it would take that long if you had pharmacological elimination. Also, there's a theory going around that perhaps this vast amount of S antigen produced from infected cells has a direct immunosuppressive effect, and perhaps it's dampening down the ability of dendritic cells or antigen-presenting cells to present antigen. Perhaps it's actually playing a central role in immune exhaustion through the checkpoint pathways, PD-1, CTL4. What's the evidence of this, that this is really happening? It's largely circumstantial. Some evidence that's not direct is that levels of, as we heard, of hepatitis B S antigen following interferon treatment has negative predictive value. If you don't have a decline of S antigen within 12 weeks of a certain amount, half log or log, there's almost a certainty you will not benefit from interferon, sustained virological benefit. There's positive predictive value. Pre-treatment levels of S antigen in a patient and post-treatment decline it correlates with outcome. Again, taken as a rule, less S antigen, better outcome overall. Spontaneous loss of HBsAg is associated with greatly reduced risk of liver cirrhosis and liver cancer, just to drive that point home. So what's the direct experimental evidence that SAG really plays a role in some kind of extra virological, let's say, immunosuppressive event? That's a little more dicey, but there is a growing body of evidence. This is a 2009 paper that I took the illustration from Optenbauer, showing that actually if you incubate hepatitis B surface antigen, a microgram per milliliter, I think that's what they used, in tissue culture with dendritic cells, but this has been done with T cells, and I'm losing my mouse here. Just zooming down here, you can see in those cultures that got S antigen, their dendritic cells were far less able to participate in T cell activation. This is interferon release, and this is basically showing a suppressing effect directly by incubating S antigen with the immune-presenting cells. Recently, there's a paper by Chu et al. Showing that this is a mouse that has artificially delivered hepatitis B DNA to it, so the DNA can replicate and you get the various viral gene products. It's obviously not an infection model, but what I'm showing you here is that if you actually deliver neutralizing antibody, and that's what's shown here, neutralizing antibody at various points, you'll see obviously a profound drop in S antigen right here, an S antigen, so neutralizing antibody, no big surprise there. But now if you vaccinate at 2 and 20 weeks with just NGRX-B, standard S antigen, a big pop in antibody, suggesting that, well, maybe it is true that S antigen, eliminating it allowed these animals to have their tolerance broken. Just recently, a couple months ago at the hepatitis B meetings, and I made this illustration myself because I became nervous. There was a poster, and I didn't want to present their data without permission because it wasn't published. But from my notes, this is what they presented, and I confirmed this with some discussions. This group, the poster 91, Lou Gao et al. From Roche, made artificial CCC-DNA, injected that into an immunocompetent mouse. And that mouse is able to establish a persistent geno-infection, you would say. It's obviously not going to be a reinfection, but those animals can continue to make gene products. And the wild-type virus, you can look at intrahepatic DNA levels and other viral gene products for some time, out to many weeks after injection, and it's doing fine. If you knock out the e-antigen or core protein coding ability, it declines a little more rapidly, but it's still there for a long time. You'd call that persistent. If you eliminate S antigen, I thought this was really surprising. If you take away the ability of this virus, cccDNA, to make S antigen, it cannot sustain its chronic infection. That's very mysterious to me. And what's lacking is some restoration experiments, but it's very provocative, very circumstantial. So that's a summary of some of the information. I'm keeping a tab on the time because I don't want to go over, but that's basically a summary in a nutshell of some of the experimental evidence that S antigen plays a role in chronicity. It's pretty scanty. Let's look at some of the molecular basis of HBsAg secretion or morphogenesis, which is complicated, but it will suggest to us a number of sites of intervention in these cells, because remember, the production of these particles inside a cell is an extremely unusual thing for the cell to do, to move these particles around, except the only analogy is, of course, the LDLs, to my knowledge, or the VLDLs. So hepatitis B surface antigen is produced, you can't see it here, from the subgenomic RNAs, or in the 2 to 2.5 kb transcript region, and I pointed out because they may be regulated differently and controlled differently than the whole genome, pregenomic RNA. The protein synthesized at the ER, I'm not going to go into all this. I just want to point out that it is N-glycosylated and variably glycosylated, and then it moves from the ER to an intermediate compartment, maybe in the same way that the LDLs, VLDLs do, with the assistance of the multiple transportive vesicle protein, which moves VLDLs. And then here, the several particles via Golgi process are secreted without docking into the L proteins, which are sitting here in the MVPs, MVB vesicles here, through the action of NED1 and gamma-adaptin, which then adds on L protein, and then you get the virions that are secreted. I only go through that in a labored way to point out there are many steps within the life cycle and morphogenesis that are prospects for intervention. Now let's talk about some of the examples that are out there. There aren't that many. The protein folding inhibitors that we introduced, the small molecule inhibitors from Arbutus and Roche, some of these come from us as well. The nucleic acid polymers, the NAPs from Replicor, of course, monoclonal antibodies, and RNAi and cccDNA inhibitors are essentially S-antigen inhibitors. I don't have time. I don't want to go through all this detail, but I do want to tell you about this Iminosugar protein folding inhibitor that we introduced, because it does something that none of the other ones do. This is the drug here. This is the infected cell here. All I want to call your attention to is generally in an infected cell, this is a CTL epitope that is loaded onto MHCs, and it has the asparagine here where the glycan is. But in the presence of these glycan processing inhibitors, the protein is pushed into the proteasomes. Its glycan is hydrolyzed off, and this asparagine is hydrolyzed into an aspartic acid. So you have actually made an editope. You've made an antigen that is not present normally in the infected cells, and in the presence of the drug, it's only in the infected cells. So it introduced, at least in theory, the possibility of immunizing against this epitope, and that's what we did with Bud Tennant, and I'm just showing you here in a paper we reported that we were actually able to treat the chronically infected animals with the aminosugars, vaccinate them, and in each case you got of these animals, you actually got a cellular response to this editope, as I dubbed it. Now it was, I would say, a biochemical experimental success, but a therapeutic failure because there was very little reduction in actual viremia. There are also small molecule inhibitors that are coming out now to treat HBsAg. And again, here, this is just a drug we call Lipavir, which actually interferes with the virus's ability to interact with the LDL secretion pathway, which we think is integral, and I'm just showing you here from Andy Cucinotta, showing a reduction in both LDLs and also in the HBsAg in tissue culture. This was also repeated in the Phoenix biomouse. Roche has a small molecule coming out that I'm very excited about. We don't know its mechanism. We have our theories on it, but I think that's already entering phase 2 clinical trials. And of course, now most notably is the Replicor product, which is a nucleic acid polymer of purines and pyrimidines. I guess this is a 19-mer. And I know Andy Valiant's here, and they've just published very, very exciting papers showing a lot of promise. These are people who are treated with the Rep 2139, and you can see in, I think it was 8 out of 12 individuals, profound reductions in S-antigen as just weeks after parenteral injection of this molecule. And most notably, worth pointing out is, in a number of these individuals, spikes in HBsAb. And this occurred not in months and years, but in really a matter of weeks. And I think the majority of the individuals who had a reduction. These individuals also, of course, lost or had great reductions in HBV DNA. So, you know, by all definitions, these individuals would be meeting the standard of functional cure. We're all obviously very expectant. We want to see more and see in greater numbers of patients, and where the chronicity is longer perhaps than in greater numbers, but this is a very exciting result. So current inhibitors of hepatitis B virus S antigen work at the level of inhibiting secretion. Maybe some actually work at the level of formation of the S antigens. We have to talk about what happens when S antigen would build up inside a cell. That's also a very important issue. Or maybe some work on actually the metabolism of S antigen and turnover of it once it's in the circulation. I summarize here the 4 leading examples of S antigen inhibitors, and that will be obviously on the Hepatitis B Foundation website. You can check that out, or in some of the review articles. So in conclusion, and I think I was able to end a little bit short here. The point I want to make is hepatitis B surface antigen, it's an essential viral protein, so inhibitors of it should have as legitimate a chance to control or manage viremia as much as any as any direct-acting antiviral. And with the concern of S antigen coming from integrated copies, if that continues to be a problem in infection, direct-acting drugs that target S antigen should be considered. But S antigen almost certainly has an extra virological role as in maintaining chronicity, and I think that there's a growing consensus that management of S antigen, it's going to be considered to be a standard of the new functional cures, is going to be very, very important. The other nice thing about S antigen inhibitors is that they're compatible with direct-acting antivirals in terms of endpoint evaluation, just in terms of using standard endpoints. Obviously, the current nukes are not that effective at reducing S antigen, so it's easy to use this as add-on therapy to look at the enhanced value of the extra value of your drug. So I'm just going to skip that and go to my acknowledgments, and thank you all very much.